Good afternoon and welcome to our March version of our panel discussion, expert panel discussion. Today we are going to be recapping some of the things that we talked about last month and which pertain to ventilator-induced lung injury. And then we're going to move forward and talk about some other nuances. Thanks for joining us. And before we get started, I want everybody to introduce themselves. My name's Keith. I'm a respiratory therapist, and I live and work in Virginia. Tom?
My name is Thomas Brano. I'm a respiratory therapist in Canada.
Brady?
Brady Scott, respiratory therapist up in Chicago.
Donna?
Donna Tanner, respiratory therapist, Cleveland, Ohio.
Sarah?
Hi there, I'm Sarah Vazalik. I'm a respiratory therapist from Milwaukee, Wisconsin.
And John?
John Ancrott, flight respiratory therapist, Advent Health Orlando, Flight 1.
And thank you to all of our panelists. Tom will put the slides up in a moment here. Eric Kreiner will be joining us a couple minutes late. And as always, just as a reminder, this obviously is live for all of you out there. But Tom records these and we put them up on our Inspire YouTube channel and LinkedIn soon after the discussion. So today we are going to recap part one, which was an introduction to ventilator-induced lung injury. We're going to move into patient self-inflicted lung injury, some nuances that have to do with non-invasive ventilation, and do the same, discuss whether or not we think that the same criteria apply with non-invasive ventilation as they do with invasive ventilation. And then finally, we will discuss the audience. Anybody, you can ask questions during this discussion, and we'll try to get to them.
Who's going to do the recap?
So if you move to the next, I think it's the next slide.
Yep.
Okay, so
here you go. This is the recap.
This is the recap, as implied by the title of the slide there, Tom. Nice.
Yeah, I was a little slow on the update.
Our last month's discussion, we really went in depth about ventilator-induced lung injury and what causes ventilator-induced lung injury. So ventilator-induced lung injury is, as it implies, the injury that's caused by the ventilator and the ventilator parameters. If you think about, maybe we can start in the year 2000 with the ARMA trial, where the ARDSNet folks did a trial with two groups. One group getting 6 milliliters per kilogram predicted body weight of tidal volume, and the control group getting 12 milliliters per kilogram predicted tidal volume. And, despite the fact that oxygenation was better in the larger tidal volumes and acidemia was better in the larger tidal volumes, in fact, outcomes were worse. So we could start earlier than that. And we may talk about some papers that describe some of this before that. But if you think about the data and the primary focus on mechanical ventilation in terms of outcomes since then, a lot of work has been done looking at pressures. If you look at Amato's paper in what year was it, Tom? 2015?
2015.
Yep,
Yeah.
2015. Yep.
That looked at driving pressures, retrospectively looked at a whole bunch of ARDS papers, and realized that there seemed to be a stronger correlation with driving pressure than any of the other variables that were looked at. And that correlation was approximately 15 centimeters of water pressure of driving pressure that was more closely associated with worse outcomes. And so if you put that in context with the term ventilator-induced lung injury, you can make the correlation that the ventilator is causing positive pressure changes in a lung that is not used to seeing positive pressure, that is more adept at negative pressure or passive pressure, then we think that's one of the causes of ventilator lung injury. And to sort of put a little bit of a finer point on it, if you think about outcomes in mechanical ventilation, we're talking about anybody that's on, we're going to talk about anybody who's on non-invasive ventilation also, but anybody who's on intubated or has an artificial airway and that is being managed on a mechanical ventilator, not just the ones with ARDS. A lot of this data is driven by sick ARDS patients. Then, if you think about ARDS specifically, it still has about a 40% mortality rate in patients who have moderate to severe ARDS. And so, if you drill down into it even a little deeper than that, that mortality rate consists of about 1 out of 10 of those people who do not survive die from hypoxemic respiratory failure, and that's a very small number overall. And so people don't die specifically from hypoxemic respiratory failure. The other 9 out of 10 people with ARDS that don't survive, the other 9 out of 10 at 40%, die from multi-system organ failure ultimately. And we believe that a large percentage of that, I don't think there's data that specifically guides us in a direction of like what is it specific, but they die from multi-system organ failure, and we do believe that a large percentage of that in intubated patients is caused by the ventilator. So that's ventilator-induced lung injury. Tom, you want to add to that at all?
Not so much. You're right. I'm gonna queue up this study here. This paper by Art Slutsky and Marco Ranieri in New England Journal of Medicine in 2013 really talks about a lot of the underlying effects and how they result in multi-organ dysfunction. So again, coming from the lungs, there's these biological alterations, release of mediators, translocation of bacteria, etc. So there's multiple mechanisms that are all linked back to the fact that the ventilator can cause injury. And I'll put a link to this paper in the chat as I normally do.
Yeah. So the easier way to sort of describe that, I think, is that when you cause an inflammatory process, whether or not it's in your ankle when you trip on a curb, or no matter what your injury is, in this case, we're talking about a primary or secondary lung injury. When you cause that inflammatory process, those inflammatory mediators, which is well studied, go on and circulate systemically and involve other organ systems in the inflammatory process. And so the lungs are not exempt from that. And so the inflammatory process in the lung is what causes this cellular edema and intraalveolar fluid and dysfunction with gas exchange, a decrease in compliance. Hopefully we can show that slide with the CT scans at some point in time like we did last time. But so if you fast forward from ARDSNet that said, hey, larger tidal volumes are bad, I think that what we get from the majority of what we understand now says, volumes are bad, but it's probably more about the volume as it relates to the amount of space in the lungs for that volume to go. And what do we measure on the ventilator to evaluate or as a surrogate for that relationship between the volume and the space available for the volume? And that, of course, is pressure. And so plateau pressure, driving pressure, et cetera, et cetera.
Yeah, and I think one of the points you made last time was that if you had two different patients, like patient B in the upper portion where the amount of collapse, whether you're on 5 centimeters of water or 45 centimeters of water, is similar. Therefore, PEEP may not be as beneficial. But if you put the same tidal volume in the patient above that you did in the patient below, even if they were the same ideal body weight, clearly there's a lot less space in this baby lung here, in this area here. However, this patient also has some potential for recruitment when you apply PEEP. So again, the whole idea of driving pressure is that it's normalized to the size of the lung. So putting 6 mils per kilo in this patient is different than putting 6 mils per kilo in this patient, and therefore the resulting injury is going to be greater. There may be some potential benefit of PEEP in this patient, but you're still dealing with a significantly less amount of volume within the lungs to receive the volume you're sending. So we focus a lot on 6 mils per kilo of predicted body weight, but it may not be appropriate for all patients based on the size of the lung. And this is where driving pressure comes in, because it's just driving pressure. As you know, the calculation is just plateau minus PEEP, but you can also, the way it's explained is that driving pressure is tidal volume divided by respiratory system compliance. So the amount of volume you put in the lung, the resulting potential for injury depends on the compliance of the lung. But if you work out the equation, tidal volume divided by respiratory system compliance, you end up with plateau pressure minus PEEP. Mathematically, they're identical.
Right. And so some of the talking points from Amato's paper and then things that, data that's been published since then has been, if you increase exactly what Tom just said, if you increase the PEEP and the driving pressure goes down, that's associated with better outcomes. If you increase PEEP and the driving pressure stays the same, it probably doesn't affect outcomes. And if you increase the PEEP and the driving pressure goes up, then that is associated with worse outcomes. So it's fairly, if we're talking about PEEP specifically and how to mitigate ventilator-induced lung injury, then that's sort of a good way to think about it and to approach it.
Yeah, and for those who aren't familiar with this graphic, I know we mentioned it last time, but some people here may not have been here for part one. But essentially what they did in this paper is they took thousands of patients from a variety of studies, and then they matched patients. So on the far left, you have patients that are matched for PEEP. So you have patients that are all on the same level of PEEP, but of course they have different plateau pressures. So they're matched for PEEP, but the plateau pressures are different. And of course, because plateau is different, you end up with a difference in driving pressure, which is plateau minus PEEP. And you can see with those, in these patients here, the higher the plateau pressure, the higher the driving pressure is. Now you might say, okay, well, that's just easy enough. I can just say that patients with high plateau pressure are obviously going to have more injury. And that's what this is telling you down here. It's the multivariate relative risk of death in hospital. And it's increasing above 1, which means the risk of death is increasing. But if you want to talk about plateau, if you move over here, you see these are patients all with the exact same plateau pressure, with various levels of PEEP. So these patients are on higher level of PEEP with the same plateau. And of course, if you have the same plateau as this patient, but you're on higher PEEP, your driving pressure is less. And patients with lower driving pressure, even if they all have the exact same plateau pressure, have a reduced mortality compared to patients that have the same plateau on a lower PEEP level, again, with a high driving pressure, meaning a worse outcome here. And then here we have patients with different varying or increasing levels of plateau pressure and increasing levels of PEEP. And you can see across all these examples, the driving pressure is the same and there's no impact on outcome here, which is why the line is essentially flat.
So one could say in terms of, does anybody else have anything to add? Sarah, Donna, anybody?
You're doing a great job recapping it.
I think, this just is emphatic of the multiple variables that we really need to consider when we think about lung injury. Certainly volume, but you look at Didier Dreyfus's work when they did the thoracic strapping, and they showed that high pressures not necessarily, equilibrated to lung injury, whereas the ones who didn't have that and had the higher tidal volumes, those lungs showed an increase in edema. So in that case, it was more volume than it was pressure. So we just can't look at one certain thing and say, well, this person's recruitable or not. We got to look at the volume. We got to look at the pressure. We got to look at if they are PEEP responsive, like we've talked about here. Because attic trauma is real. And the bacterial translocation that can happen because of ruptured alveoli, that can lead to your multi-organ dysfunction. So a lot of things we need to look at. And, it's not as easy as 12,500 plus 5 and 100%. So again, this is very good leading up to what we're going to talk about when it comes to non-invasive and PCILI.
John, are you trying to say that mechanical ventilation should be individualized to the patient?
I am emphatically saying that it should be individualized to each patient. Absolutely.
Very good. Anybody else? So if
Great job, Keith.
thank you, sir. So we've sort of talked about what VILI is, ventilator-induced lung injury. We've talked about what we think causes it. And when you evaluate the data and the literature and you really start to try to dive in and learn as much about this as you can, and quite honestly, and what I tell people, if you take care of patients that are on mechanical ventilators, you should absolutely spend a fair deal of time sorting this out and trying to learn as much about this as you can. And that's one of that's really our mission here with this volunteer nonprofit group that just puts these things together and tries to get out there, is that we're trying to explain to you that the role of the respiratory therapist or anybody, the physicians that are taking care of ventilator patients is to be the expert and to understand what these things mean. What does it mean when I turn up the volume because I'm not happy with the pH on a blood gas? Is the benefit of making that change worth the risk that I'm potentially exposing the patient to? And so we're just really trying to get these things out there and get people to discuss them. So that's what we're doing here. So what is VILI? We talked about that. What causes VILI? We think that I sort of forgot where I was going with this, but when you really get in there and you look at this stuff, you'll see terms like stress and strain. You'll see terms like mechanical power and the equation of motion. And I think really from a, it's good to understand all of these things and to have a good grasp of what these things mean. But I think in a practical sense at the bedside for your average everyday person that's got to take care of these patients is to know what increases those things and what increases the risk to the patient primarily. And so if we think about what we've already gone over last month and what we're talking about now, more volume has the potential to increase the amount of energy applied to the lungs, which is bad. More pressure has the potential to do that. If volume and pressure have the potential to do that, then the rate or the frequency during a minute, the respiratory rate increases. It has the potential to do that. And they're not equal potentials, but they still increase energy applied to the lungs. So how do we go about reducing the opportunity or mitigating ventilator-induced lung injury? Well, we simply think about the risk and the benefit of everything that we do with the ventilator, right? If we know we go up on the volume, the energy is going to be higher. We know we go up on the pressure. So we monitor things like tidal volume. We start out with a reasonable tidal volume that's, and most people would say somewhere between 6 and 8, I think, for most people. We monitor plateau pressures. We monitor driving pressures. We use PEEP to prevent atelectasis trauma and to prevent the energy that's applied to the lungs via atelectasis and reopening and closing. And then finally, we try to use the lowest FiO2 that we can get away with, because there's some data that talks about higher FiO2s are injurious, particularly in some subsets of patients like reperfused cardiac arrest patients and people like that. So all those things are really, really important. Anybody have anything to add about the recap?
No, I think that pretty much sums it up. We didn't get into mechanical power again, but just understand that it's multiple components of the ventilator settings that are included. There's data suggesting that it doesn't necessarily offer more information than just looking at driving pressure and respiratory rate. In fact, I can quickly share this tab here. This is just a paper. Mechanical power is associated with mortality. There is no question. This is mechanical power here. When they break down mechanical power into its dynamic elastic related properties like driving pressure, you can see that that's where it's associated with mortality, whereas the level associated with PEEP, or the component of the power equation associated with PEEP, not so much, and resistive pressure, not so much. And when you just take driving pressure, 4 times driving pressure plus respiratory rate, you end up with a value that is highly predictive of mortality. Is there a cutoff point? No, the whole point is that if you're adjusting anything that increases driving pressure, or if you're adjusting the respiratory rate, you can calculate whether or not this value is going up or down. And if it's going up, this is not beneficial to the patient. If the result is that it's going down, this is beneficial for the patient. And again, when they compare 4 times driving pressure plus respiratory rate compared to power, this some very simple equation sort of outsmarts it. But when it comes to mechanical power, if you're a fan of it, there are easier formulas to calculate with mechanical power. There's these very comprehensive formulas, which are quite long, but if you're using volume assist control, this is a simplified equation here, and I'll share the link for these papers in just a moment. And if you're on pressure control, it's an even simpler equation here, right there. So there are ways of calculating mechanical power. Again, the data doesn't fully agree on a threshold of mechanical power, and I think the reason why some data has different cutoffs for whether or not it's harmful or not is because of the confusion over whether or not PEEP is beneficial. If you add PEEP to a patient who doesn't recruit, the overall effect is going to be negative, and therefore the increase in mechanical power makes sense. But if they're highly recruitable, the increase in mechanical power may not be associated with the same outcomes. And that's what this paper by Costa showed, that when you take the PEEP-related component of the power equation, you have basically there's no difference in outcomes when you just look at that. So it's likely because it's confounded by whether or not the patient has recruitment potential.
Keith, I have a question for you. So I wasn't here the last time, like basically part 1 of ventilator-induced lung injury, but what conversations were had about the respiratory therapist's role in basically improving lung homogeneity or decreasing lung heterogeneity using, proning to improve the physical characteristics of the lung in the setting of ventilator-induced lung injury and ARDS. Did we talk about that?
I don't think that we spent a lot of time, if any, talking about proning. We did talk some about the different ways of sort of.
Well, I think we talked mostly about the causes rather than the treatments.
Yeah.
Okay. I mean, the reason I bring it up is, I probably categorically fall into that group of RTs because I've been doing this a long time that used to really fight against prone positioning because the data didn't support it. Used to argue the data. And then 2013 came around and the Proseva study, I'm like, okay, apparently we have to rethink this. And sometimes though I get in conversations and I feel like prone positioning is oftentimes considered as a way to improve oxygenation, but I would argue that prone positioning is a strategy to reduce ventilator-induced lung injury and appears to be quite effective. So I just didn't know if there was a conversation on that. But, we don't have to have that conversation. I was just wondering if it was thought of.
Yeah, that's a really good point. I think that it's important to talk about this. It's important to understand that an improvement in oxygenation or gas exchange in general, but oxygenation specifically, does not correlate well all by itself with improvements in outcomes.
Right.
The ARDSNet trial, clearly the PO2 was higher in the control group than in the study group, and the study group did better. Things like we used to use the oscillator, like when we were growing up. We used to love to break that oscillator out, right? And we don't do that because despite the fact that in 80% of the people we started the oscillator on, the gas exchange got better, but in fact the outcomes were not better. And I think that nitric oxide, gas exchange gets better, outcomes either worse or not better.
Mm-hmm.
Proning does obviously improve gas exchange, but I think you're right. I think that most people would argue that it's not the benefit of
Right.
the higher PO2s that improves outcomes. It's the redistribution of transpulmonary pressure and maybe lower levels of iatrogenic inflammatory responses, right? And sort
Well,
of.
I think to make it simpler, you don't cram your tidal volume in the ventral lung regions, and then the dorsal lung regions lie there and silently be quiet. We could redistribute the tidal volume. But I guess the point is, and I don't want to beat this into the ground, was, when I heard you do a nice job of explaining, and I think John had mentioned it too, the effects of ventilator-induced lung injury on creating or being involved in multi-system organ failure, which I think is sometimes termed biotrauma
Right.
when you look at that in the literature. But I guess it's just I just wanted to mention and get your all's thought of, when I think of prone positioning, I actually think it as a lung protective strategy to maintain people, to keep them safe, keep the lungs safe, and try to create a safer environment for mechanical ventilation rather than a rescue strategy to try to get their saturations to come up.
Brady, I would almost argue too, some of your work that your team has done for awake proning would also be something you could talk about as being a strategy for preventing PCILI and spontaneously breathing patients.
Yeah, the paper just came out in JAMA Internal Medicine that pretty much shows that it's flipping people over early, even for the awake prone position. I realize it's not the topic, but keeping them flipped over for a long period of time, 8 to 10 hours at least, and then doing it early is beneficial. But anyway, I was just bringing up lung protective, the strategies to reduce the negative effect of ventilators is sometimes just flipping somebody over so we can improve the lung characteristics.
Right. Yeah. It's definitely a method of reducing villi for sure. And the use of neuromuscular blockade could be put in that category too. I think that despite the fact that oftentimes the use of neuromuscular blockade does improve gas exchange, but it also can reduce some PCILI component, which we'll talk about soon, but also villi. I'm sorry, Tom.
Oh no, I was just going to add to the point that Brady was making, that prone positioning, I know the criteria for whether we continued to prone people a lot of the time was whether or not the PF ratio exceeded a threshold or not. But I think you highlighted nicely that it's not just the blood gases we're looking for. There is a redistribution of injury, a potential for injury, or whether you want to say a redistribution of power within the lung. And that's even if the compliance or the driving pressure doesn't change much. And this is an animal study. This graph I'm showing here by Bouchard and Katira. And what's interesting is they have the animals in the supine position, and they've put regional sensors in the dependent and non-dependent zones so that they can measure regional transpulmonary pressure, or essentially regional lung compliance, versus the total respiratory system compliance. And what's nicely demonstrated here is that this is respiratory system compliance, and you would assume that the optimal compliance of the lung is a good spot to be, but it's actually regionally different. So the respiratory system compliance in these animals in the supine position mostly reflected compliance in the dependent lung region, but the non-dependent lung region, which is usually the area that is most at risk of injury because of the baby lung, the optimal compliance, or the best compliance, is at a very different PEEP level. So much lower PEEP level is where this area of the lung, the non-dependent region, is more compliant. In other words, receiving probably less injury. Whereas if you just go by respiratory system compliance, sure, the dorsal lung region or dependent lung region might be better off, but you're at a lower lung compliance in the healthier region, meaning you're probably over distending that region. In the prone position, what this graphic is nicely showing is how it starts to homogenize the potential for injury across regions. And I think we underappreciate this potential with prone positioning, and we just focus on the blood gas, but really there's other stuff going on here that really helps to minimize the potential for injury.
Did you put that paper in there? I don't think I've seen this. Did you put that in
I'll put it in the chat now. Yeah.
What journal is this?
This is the Blue Journal.
Huh?
I believe.
Yeah, it looks like it.
Yep, Blue Journal.
So I hadn't mentioned it yet, but Eric Kreiner joined us. Eric, thanks for joining us. Do you want to introduce?
Yeah, I came in late. I'm kind of surprised that you guys don't have this all wrapped up already after just decades of questions. You don't have this figured out in the first 20 minutes or so. Yeah, so I'm just kind of listening along and kind of wondering when we get to the point of kind of how we monitor for these things, right? I think that's kind of the next, in my head, the next, Brady put in the idea of prone positioning and prevention of, but kind of how we go about better monitoring for these ideas of these mechanisms of lung injury, because it's kind of the next sequential, like we've defined it. How do we know that it's happening? And then how do we react, right? In this kind of pathway of treatment for them. And I think that's kind of also the hard part, right? Because of just what Tom showed us, is that you have these regional differences, and we have really blunt instruments outside of EIT that are widespread. And so I think you can see why we get ourselves into trouble a whole bunch, right? Just what you mentioned with driving pressure and everything else. They're super blunt. And they don't tell us about these heterogeneous regional differences. So yeah, I love the recap that you got, and yeah, let's keep talking about it.
I think regarding monitoring, I feel like we're definitely hammering the point home that driving pressure is probably something that everyone should be monitoring,
minimum, right?
At minimum. And and for those who have known me for a long time, they know that I've been a huge proponent of esophageal pressure and transpulmonary pressure. But to be perfectly honest, in the majority of patients, it doesn't provide more information than driving pressure. And that's just, I'll share a study that shows that. Having said that, if you have an obese patient, I would 100% recommend putting an esophageal balloon without question. If you have if your patient population is made up of a lot of obese patients, you should absolutely 100% be using esophageal pressure monitoring, because you will find that you require PEEP levels that no one in your department would be comfortable using unless they've used esophageal pressure on these patients before, and then maybe you'd have a little bit more freedom to feel comfortable with it. But this just allows you some sort of guidance. But in terms of the driving pressure, obviously it's a very useful tool. And this paper by Lu Chen and colleagues, they actually looked at elastance-derived transpulmonary pressure, which regionally reflects the non-dependent regions. So at most risk of injury, because this is the baby lung essentially. And then they looked at driving pressure less than 15. They looked at transpulmonary driving pressure. And of all these variables, the one that distinguished the survival probability the best was actually just simply airway driving pressure of 15 centimeters of water. So it doesn't negate that this is useful, but this is definitely very useful. Now, they do have another table here with obese patients, and they found that targeting a transpulmonary pressure of 0 in obese patients, there was a clear benefit. There's a clear survival benefit when they looked back at these patients. Again, this was a retrospective study. Whereas when they looked at all patients, looking at a transpulmonary pressure of 0 in all patients, there was not a significant distinction between survival in patients that had transpulmonary pressure and expiratory transpulmonary pressure less than 0 versus over 0. And again, this would likely be because many patients that you're targeting this may not be recruitable, and therefore it's not beneficial. And then patients that it's less than that, maybe they were recruitable, but they didn't have sufficient PEEP. But when you look at obese patients, almost always an obese patient, I can't say always, but almost always they are highly recruitable. We are just under PEEPing them significantly. So there was a clear benefit when they just narrowed it down to obese patients. So at least of all things, the least thing to do obviously is monitoring driving pressure, whether or not you want to include driving pressure plus respiratory rate or mechanical power. These are all things that we should be looking at that tell us more of a picture than just your blood gas. Certainly doesn't tell you that you have ventilator-induced lung injury. It tells you have bad gas exchange, but you may not be facilitating the worsening of ventilator-induced lung injury. But of course, a rise in driving pressure after a ventilator change or a rise in mechanical power after a ventilator change may indicate that you are now heading down the wrong direction with the potential for VILI.
Practically, does anybody actually measure mediators and inflammatory mediators and level of inflammation? I know that people in animal studies have certainly done that, but I don't know if is there a test that we can do to gauge the amount of inflammation?
I don't believe there's something easily done at the bedside. And I think that's the more complicated part, is that some of these tests require sending blood away. And by the time you get results back, it may, and again, I've heard people talk about mediators and how they can be a little bit misleading in some cases. There are definitely some that are very much linked to ventilator-induced lung injury, but they can also be present in other types of injury. And therefore they can be a little bit, there's some confounders that need to be considered, but there's nice studies looking at phenotypes of patients related to their mediators, and there's definitely a distinction. And some patients with hyperinflammatory versus hypoinflammatory, their response to PEEP is also very different. So precision medicine eventually is going to be, perhaps driving pressure is the major flag, and then perhaps looking at the mediators to see whether or not this is one type of phenotype or another, and then whether or not you use PEEP to respond to this. That really is the future, but we're not, as far as I know, we're not at it at the bedside in terms of like rapid assessment of IL-6 or IL-8, for example.
Yeah, I agree. I don't think we are either. So to bring it back to practicality, if a young RT or whomever comes up to you and says, how can I mitigate or reduce the opportunity of hurting the patient with the ventilator? Then what do you tell them? You tell them monitor driving pressure, right? Start out with a reasonable tidal volume, measure plateau pressure, measure PEEP, monitor that driving pressure. What else do you tell them? What do you tell them about the mode of ventilation? What if somebody, so we're going to move towards having to have a part 3 here if we're not careful, right? But and maybe that's what we do. But let's if an RT or whomever comes up to you and says, "What's the best mode of ventilation to use in order to decrease the opportunity for VILI?" If you look at the ARSNet data, volume control, right? But does it make more sense to use pressure control and essentially set the driving pressure instead of worrying about the volume? What do you think about that, Eric?
I think that's a super scary proposition, because all you control in pressure limited ventilation is airway pressure. At no point do you ever control the alveolar pressure, right? And so that's what scares me about it, right? And that you can just ask a general group of a large gathering of high-level clinicians and ask the simple question: can a plateau or end inspiratory alveolar pressure be higher than your set airway pressure? Or ask it a different way: is your plateau pressure always lower than your set airway pressure? And invariably, that's the misconception, that people will say, yeah, my plateau pressure is always less than that. And you hear it. You hear it in really, really educated people. That is shocking sometimes, right? And so, outside of a completely paralyzed, anesthetized patient, that's a scary proposition. As soon as you add PMUS and effort into it, and you are no longer controlling volume and never having control of alveolar pressure, I think you get yourself into a bind really, really quickly, with unmitigated patient effort with that, right? So,
I just put a graphic up for you, Eric, just explaining when someone's like, what do you mean the plateau pressure could be higher than my set pressure? And this is an example. You don't normally see the effort of the patient, but if your ventilator allows a plateau pressure during pressure support ventilation, then if you see this happening, this just indicates this is essentially it's the elastic recoil of the lungs, and the absolute driving pressure is the true driving pressure that the patient's probably feeling rather than what we see on the ventilator. So it's confusing when people do this and they think something's wrong with the ventilator if they do this, but this is actually the difference between this and this is called PMI. It's a pressure muscle index. I'll put a link to this. There's a full article that it was written for the blog that I manage. I'll send that for people that want to learn more about that.
So what's your answer, Rick? What do you tell that person?
I would not use ACPC if your neurologic management is of question, right? I think that's the transition point, right? If a patient is relatively passive, I don't know that we know that any one mode is better than any other. However, as soon as your neurologic management, and that's the fight within critical care medicine, let's let the patient up, let's wake them up, et cetera, et cetera. And so now you have patients that have significant respiratory effort, and the use of pressure limited ventilation is troublesome, right? You have to be super attentive to it, especially if you are in a volume targeted mode of that, in which it decreases its level of support and only kind of propagates that. So I know I waffled on that, but if the patient's super sedate, then I don't see the big difference, right? However, as soon as they are not, there is a tremendous difference in what the patient can self-inflict upon themselves. And I don't know that I would use that. Not to say that they can't hurt themselves in volume control either, right? From Penduleft, but at least they would not have excessive volume in terms of that. So,
yeah.
So before we get to
I don't. Just Keith, just so you know why I'm putting this on here, because I don't think the comments come through on the videos. And since I answered this comment in the question, or I answered this question in the comments, I feel that it wasn't part of the video. So I just threw this up there quickly because someone asked, like, is there a threshold for respiratory rate? And essentially I was just showing that it's relatively linear. That was the question that was asked. And I said, yeah, it's relatively linear, whereas driving pressure is a little bit more exponential, not quite as linear, but it's 4 times as worse than respiratory rate. So I just wanted to quickly throw it in there so it's in the video. And then
Okay,
I'll take it away now.
Thank you. So that being said, anybody just jump in here before we move into what Eric just sort of eloquently described, which is patient self-inflicted lung injury to an extent, right? And we're going to talk about that more in a moment. Is there a role for volume targeted ventilation? PRVC, autoflow, anything like that? That's a volume targeted mode of ventilation.
Because
you want to hear my bias?
I think it's loaded.
Yeah, you want to hear my bias?
Yeah.
I'm trying to draw this out, Keith.
Go ahead. Right, we have 20 more minutes. Part 3 coming up.
I think a volume targeted or pressure control adaptive, however you want to talk about it, in whatever nomenclature taxonomy form that you want to talk about it, is exceptionally, it's scarier to me than even with a set pressure in patients that have a high respiratory drive or high demand. Because its level of support will be titrated downwards in a patient that actually probably demands a little bit more support. So the ventilator makes really bad decisions in the face of patients with high demand. And if you think about these particular patients that we're talking about, very few of them are hanging out, relaxing with minute ventilations less than 10 and low to minimal demands. Right, you're talking about pretty high demand patients, and so those guys are particularly scary. Further, I think what is even scarier is the misleading number that is on the dial that tricks people into thinking that they are indeed volume limiting this patient's ventilation. I wish they would just label it with like a big red volume target instead of set volume or otherwise indicating in some way that is a set or guaranteed volume, in which it clearly is not. And so those patients, just like with pressure control with a set variable, in the face of a high demand, you don't control the volume, and therefore you do not control alveolar pressure. Right.
And I've worked in hospitals that exclusively use PRVC as a mode. And the number of times I've been called to the room for a low pressure alarm, which I know is because the patient's demanding more volume than the machine's wanting to give. So it's, as you said, it's making bad decisions in the face of strong effort. So it's reducing the support to the point where your low pressure alarm is going off. By the time I get there, the nurses have resedated the patient. And this is that the minute I get there, I'm like, no, please don't do that when this happens. And some respiratory therapists don't understand that that's what's happening. They just feel like, oh, the patient's not comfortable. Can we increase sedation? Like if you're asking to increase sedation to fix this problem, or your nurse is automatically doing that, there needs to be a huge change in culture. The minute someone has a strong demand like that, just switch them to a regular pressure targeted mode. You can use pressure control or pressure support, but keeping them in the mode where they're going to outstrip the ventilator support, it doesn't make any sense.
I feel like as a leader, that mode makes me very nervous, in that I think some of the ventilator companies haven't done a good job of explaining it on their machine. And then also that our RTs aren't always paying attention to the greater scheme of things, looking at their waveforms and really taking into account what that number is actually meaning to them. So I agree, Eric. It makes me very nervous to use that mode in many of our populations, and people are not looking at the greater picture, I feel like, often with that.
From an
sorry, go ahead.
I was just going to say, from an education standpoint, I tried to I try to remind folks, like my students, for example, when we're talking about what exactly the clinical situation you're talking about, Tom, is, I'm like, the ventilator is not AI, right? It's not thinking, it's not calculating all the things that are going on. It's just following instructions, following an algorithm. So you told it to hang out at a tidal volume, and it's going to try to do that based on what it's told. It doesn't understand what's going on. So when the work transfers over to the patient or whatever, it's not really seeing all that. And I think that sometimes, just in folks over the years, maybe this is just my perception, but I feel like people think that the ventilator kind of it's safer and better, that it's doing what it's doing. But I'm always just like, guys, you got to remember that it's just simply following instructions. It's not thinking about the clinical situation that you're in at the moment, which could be, for this mode, not ideal. So I think we give ventilators mode sometimes too much credit.
Yeah, and it only has one question, and it's algorithm, right? It's volume.
That's it.
Not how you achieve the volume. Anything else that's going on.
One instruction. Yeah.
One track mind. Like
one track mind. That's right.
Yeah.
Give it a little too much credit.
I could imagine an improved PRVC mode that actually looked at P0.1 when it made the decision whether or not to reduce support, and at some point being like, this P0.1 is kind of high, maybe I shouldn't drop the support. But I don't think that's ever going to happen. It's not going to happen with this mode, and essentially it's just going to constantly react poorly when a patient has high demand. In a passive patient, it doesn't really matter, really. As Troy pointed up here, he's like, no real data to support one mode over another. However, he prefers volume ventilation in a passive patient, and that's typically because you can set a rapid constant flow with a short pause to assess plateau pressure or plateau pressure breath to breath, and also look at peak minus plateau. If you set your flow at 60, then peak minus plateau mathematically is exactly your resistive pressure. So it's not so much the mode, it's about when you're using it. So if you use PRVC or pressure control or volume control in a passive patient, it's the volume you're putting into the lung. You still need to measure driving pressure. Even in pressure control, if you have high resistance, your plateau pressure won't be your square waveform that you see. So it's still worthwhile doing inspiratory pauses with pressure control. But once the patient becomes active, the mode actually does matter more.
So that you know the old saying, don't ask a question you don't already at least think that you know the answer to, partially. The panel here knows that I have a particular opposition to volume targeted or whatever you want to call it, ventilation. What about that patient and volume control ventilation, square flow, like Troy described? Now you're getting a low pressure alarm because you're not giving the patient enough flow. And so is that the patient, Eric, that you flip over to pressure control, or is that a patient that you're asking to sedate?
I think context comes into key with that. I think it depends on what your goal at that particular moment in time is.
Yeah, and if Troy, if you're still on, you should throw an answer in there, because I think it's probably going to be similar to what Eric's saying too.
Yeah, you know, I think
it's context. Yeah,
I think Eduardo and crew do with Donna there do a really good job of really delineating and kind of talking about it as much as they can. What is your goal at that particular time? Is it safety? Is it comfort? Is it liberation? Right. And so I do think that you have to take into that context, and you can't paint with a broad brush at that particular moment. Right. So if it's safety at that particular time, then yes, I do think that you do sedate the patient at that point, right? If it's comfort, then your problem isn't a brain problem, it's a ventilator problem, right? I just break it down for people like that. You're administering brain drugs, right? So if you feel like you got a brain problem, then you administer brain drugs. And it's not a brain problem, it's a ventilator problem, it's a you problem, right? And so you're misdiagnosing and you're mistreating at that particular time if you're just using drugs to solve all of your problems, if your context and your goal is comfort at that particular time. And so you got to figure out what lever to pull. And so I mean, you know, switching the pressure clearly makes the flow variable and satisfies kind of those criteria for comfort, provided you can control and somehow, you know, limit effort, right? And somehow find the pendulum or the seesaw between who's doing the work and at that particular time, and if the patient's doing too much or has significant effort and therefore significant volume and is injurious. You know, you have to kind of weigh all of those things. And so it's not an easy answer. It's not an easy answer, right? And I think
no, I have two screenshots that describe exactly what you're saying, Eric. I have and your comment, Keith. Yeah, if someone wakes up on volume assist control and they're flow starved, this is not a patient you want to keep in that mode. So we'll often change to pressure, as Troy just said. That's exactly what you should do. But is it, now you ask the question like Eric just brought up, is it still safe? So in this example, this patient was completely outstripping the ventilator. The pressure was going negative during inspiration. So it was going below PEEP. And we switched to pressure control. The tidal volume was well over 12 mils per kilo of predicted body weight. We reduced the pressure control level down to 6 centimeters of water, and the tidal volume was still 10 mils per kilo of predicted body weight. The patient was on a PEEP of 12 and 60% FiO2, and the P0.1 was like 6 or 9. Like, this is not a patient that it's, even though you're like, oh, they're on very low pressure control. It's like, but they have a huge drive. They've had this huge drive for a few days, and we just cannot settle them. And, you know, trying to, you know, you sedate them, put them on volume control, and then they wake up in this situation. So what we end up doing was deciding that safety was the most important thing. So we resedated, paralyzed, and prone this patient, right? And then you start the whole process. So this was a patient who was recovering from ARDS and then had a relapse of ARDS. Anyways, they survived, long story short, but these were the decisions. So you have to make a very quick reaction when you have someone on volume control who is starting to be active, because it will be a more uncomfortable mode. More so if you use flows of 30 to 40 liters per minute. If you use slow, like lower flows, like 30 or 40 in an adult patient, and they wake up, they will outstrip that ventilator so fast. If you use flows like 60 liters per minute, I've seen patients wake up comfortably on volume control, surprisingly comfortably, but it's because the flow is so high. But if they wake up, doesn't matter if it's 60, if they are demanding, then you can try pressure. But again, the safety becomes the next question. What is what is your goal with this patient right now will determine whether or not you decide to sedate or not. But that would definitely not be my first choice. Even in this patient, we were pretty sure they weren't going to slow their drive down, but we tried pressure targeted mode first and found that we basically were giving them nothing, and tidal volumes were still way too high.
Yeah, I think, so we never use a pressure control adaptive mode. We don't use it at all. It's never been used in my facility, and we won't use it. We start out conventional volume, but if you look at our 90 some odd ventilators running today, we are like a 65-35% mix between volume and pressure. It depends on where they are kind of in their clinical course, in their trajectory. So we'll start off volume and readily switch into pressure, whether that's all the way right, I don't know, but that is kind of like what we're talking about here. There's context involved, and you move the patient through their course at that particular time, and so we end up kind of on this 50-50 split between, or close to it, between volume and pressure. And you can see it in kind of what day in mechanical ventilation they're on, type of thing, right? It's heavy volume at the beginning of a course, and as they move on beyond 48 hours in the typical course, they end up switching the pressure. And so
in the last few minutes we have, Brady, do you want to talk about this? Because we said that we would discuss non-invasive ventilation and the risk of ventilator-induced lung injury. And I brought up this, I've had this slide there because it really talks about managing all the things we've been talking about. But the last part of this table, of course, is that information there. And just before we finish off with this explanation, I'll just quickly demonstrate this in that ventilator-induced lung injury article that I shared earlier. A patient on non-invasive ventilation with a maximum alveolar pressure of 10. This could be a patient on 5-on-5. If they have an extremely high effort, pleural pressure of -15, the transpulmonary pressure could be 25 centimeters of water. So sometimes we think we're not giving high levels of pressure, or they're on NIV. We can't possibly be causing ventilator-induced lung injury. I thought that had to be an intubated patient, but clearly it can happen with spontaneous breathing patients. So I'll let you go ahead, Brady, since I got this queued up just for you.
I have a bit of a hard stop here in about 1 minute, so
okay.
I can't elaborate a whole lot, but I will actually, for the sake of giving people some reading and homework. Keith, sounds like we need part 3 of this discussion. I don't know if anybody likes to talk about this. This is a big deal for us. I recommend going to a 2019 paper that was published by Bhushan and Katira. I think I said that right, Tom. It's in Respiratory Care Journal. I think Tom's going to post it, but it describes ventilator-induced lung injury in some interesting mechanisms that perhaps we haven't talked much about. I mean, we've certainly hit on volume trauma and this concept of biotrauma, and you can see that this what you see on the screen. If you have high tidal volume, lower PEEP, that and the recommendation from Dr. Katira is if tidal volume continues to be high, then perhaps non-invasive ventilation is not the right way to go. But I would ask you to go take a look at this adverse heart-lung interaction, lung deflation injury, and effort-induced lung injury, and how that might actually contribute to some degree of ventilator-induced lung injury in that paper. So, but I think that regardless, we really need to start thinking about the amount of patients we have on non-invasive ventilation, which I love to place patients on NIV, but the question is whether or not we can mitigate the risk of lung injury even in those folks, and be looking out for things, and at least be able to bring up for discussion for the team. So sorry, I have to go. I have to run to another meeting on the hour. So maybe part 3, we could dive a little deeper in that.
Yeah, sounds good. I think we're sort of committed to doing a part 3 at this point.
Madison said yes already.
Yeah, she said yes. She's the boss. So there we go.
I got to run, everybody. See you later.
Brady,
Okay,
thank
see you, Brady.
Thanks for everything. So I suppose we should wrap it up, but let me just ask one more question. Is there anything that we talked about today in terms of ventilator-induced lung injury that does not apply to non-invasive ventilation? I think that's an easy way to sort of Is there anything? Are we still worried about transpulmonary pressure? Are we still worried about stress and strain and energy and P-Silly? All those things are concerning, and non-invasive ventilation is as much as invasive ventilation.
I don't think there's really much anything different. I think the type of injury is going to be more common in one than the other, just by the nature of the fact with NIV, there's always spontaneous effort. So the source of injury is going to most likely be related to effort, simply because if you think about the settings we apply on BiPAP, we are limited by the fact that the masks leak, right? So you can only go so high on pressure. And so you can say, oh, well, they're only on 10 centimeters of water of a delta pressure, which would, if you had someone on like 20 on 10, be like, oh, well, the driving pressure must be 10 or less. Well, that's not the case because of the patient's effort. So I think the patient effort becomes the primary consideration, I believe, with NIV, more so than the pressures that we apply, because we have limits to how much pressure we can possibly deliver to a patient, just based on the interface. Now, maybe with a helmet, maybe you got to focus a little bit more on the pressure being applied, but I think effort is the primary component. Whereas once they're intubated, they could have no effort and still have huge signs of ventilator-induced lung injury, like risks related to driving pressure or mechanical power or whatever.
So I think moving into part 3, I think, for the homework for the audience is recognizing patient effort. And when this effort is so high, then not to let this person marinate in these settings, but to intubate these patients, because sometimes we don't recognize that. And of course, then they end up with some lung injury, which I'm going to probably surmise is P-Silly. And then, of course, we put them on the ventilator and we're behind the 8 ball because they're injured anyway. So patient recognition and patient effort.
Yep.
Excellent.
And actually, I'll let everybody know, if you pay attention to respiratory care, when the April edition comes out, there actually is a paper by a group out of Argentina that looked at non-invasive ways of measuring things like POC or P0.1 during non-invasive ventilation. There are some limitations. It's not ready for prime time. In fact, myself and my friend and colleague Felipe Damiani, we wrote an editorial for the paper, but it should be in April's respiratory care. So just keep an eye on that. And again, it's a move forward. I think eventually, because this comment here from Troy just perfectly sums it up, that aside from tidal volume, there's no good way to actually measure patient effort non-invasively, like without putting an esophageal balloon catheter. So this paper looked at non-invasive ways of measuring it. It's in a bench study. That's why there's some limitations. So if you read the paper, make sure you read the editorial as well. I'm a little biased, obviously, because I wrote that with my colleague. But I also know that there is another paper being written up where they did the exact same thing in healthy volunteers and also with limitations. So that paper is being written up for publication, but it's not published yet. But we're moving in that direction where we're trying to better identify patients at this risk of patient self-inflicted lung injury, essentially, in the presence of non-invasive ventilation.
Thank you. So part 3 it is, and we'll move in. We'll recap a little bit and then move into all the things that we just or that Tom just described. So that's it, folks. Please go to our website to recommend any future topics. I think we have April's sorted out already, but for any future topics after that. And stay tuned for the video of this that you can share with whomever. All right, friends, panelists, thank you so much for joining us today. Appreciate it.
Thanks, everybody.
Have a good afternoon.
See you.